I've basically tried to make it about what we tell patients, so that when they come to see you and their family members come to see you, then we all are sort of talking from the same sort of handbook, really. So as we know, I mean, unfortunately, pancreatic cancer is really quite bad. It's often diagnosed late, and as we know, the survival is 4% for 5 years. The majority of pancreatic adenocarcinoma, but there are a small percentage that are neuroendocrine, and then there are a number of others, whether it's metastatic, lymphoma, other things like that. Unfortunately, less than 20% of patients that are diagnosed with pancreatic cancer are eligible for any form of surgical resection. If they do undergo surgical resection, only 15 to 20% of those will survive beyond 5 years. Unfortunately, amongst the HPB surgeons, we often say if they do survive that long, they were never diagnosed properly. As you can see, with locally advanced disease, their survival is about 8 to 12 months. And if they've got metastatic disease, then their survival is approximately 3 to 6 months. So then what do we do? I mean, the most important thing that we do is basically we're a teamwork. The most important thing that the primary care physicians really should know about is the CNS. I mean, surgeons, we can operate on the patients, but the CNS is your port of call, the patient's port of call, the family's port of call. We act as a team. We don't, as surgeons, as much as we may think it, we don't do anything on our own. So this is what we think about when a patient presents to us for surgery, with a diagnosis of pancreatic cancer. It's, are they resectable? Do they have locally advanced disease? Are they unresectable? And are they fit for surgery? Why we want to know if they're resectable is basically because if we can't get the entire tumour out, and we only get, which is the R0 resection, and we could get most of it out, which is the R1, that's where there's micro disease, that's sort of microscopic disease, their survival is still extremely poor, as you can see. So why put them through this extremely severe operation when their outcomes are actually going to be quite poor? But as a pancreatic surgeon, not only do we want to know whether they're resectable, we have to worry about, if they're not, what other things do we need to care for them as in their entirety, not just their cancer. So as you know, for us, a large majority of them present with obstructive jaundice. So do they need surgery, or do they have an endoscopic procedure? They often present with gastric outlet obstruction, whether that's nausea, vomiting. It's an unusual story usually, where they can eat for days and then they will vomit at the end of the week. It's not something they often tell you about because they actually think it's normal for them. Unfortunately, only 5% of those have a mechanical obstruction, and that basically means that's only something that we can do. The majority of the others will, if we relieve their obstructive jaundice, will often resolve some of their nausea and their vomiting, but otherwise it's sort of the metoclopramide or the erythromycin that we talk about. The other thing is patient factors, nutrition factors. We know that at the Royal Surrey we've done a number of studies, and we know that about 40% of patients without any form of sort of steatorrhea or symptoms of exocrine pancreatic failure will have an appropriate fecal elastase test that puts them in the range of being exocrine deficient. And so we give all our pancreatic cancer patients Creon. Okay, it's the same with diabetes. As much as we sort of say that it's a diagnosis and it helps us sort of, it's a thing that we need to think about. We also know that about 20% of patients that we've tested actually have an impaired glucose tolerance test when we test them pre any form of surgery. And then the other thing that we need to think about is the type of operation that we do. And there's a multitude out there. I will go through some of them. I will try and limit it. Unfortunately, it's a surgical talk, so there's some anatomy. But basically, all you need to know about is the pancreas is a retroperitoneal structure. It's surrounded by all serious organs, so the duodenum, the transverse colon, the stomach, gallbladder, liver, the major blood supply to the bowel. So the SMA, the SMV, major blood supply to the liver, portal vein. So all of these things It's one of the reasons why nobody really wants to operate on the pancreas. Okay. So it's something surgically resectable, and that's basically about where it lies and what it invades. So is it left of the neck of the pancreas, or is it to the right? So if it's to the right in the head, it becomes what you'll know as a Whipple's. If it's to the left, it becomes a distal pancreatectomy or other sort of type of operations. Is it resectable? It's all about the local factors, and we're pushing the boundaries more and more these days to whether or not something is actually resectable, and I'll talk about that a little bit further down. But it's all about whether it involves the SMV, the portal vein, or the SMA, or if there's other organs. Now, if there's distant metastases, then that's a blanket, never having an operation for curative resection. These are just some CTs that you can see. So the one on the left has been marked. So there's a small tumour. You can see it's well away from any vascular structures. The one on the left is a sort of cystic lesion. It's getting closer and closer to the vessels, but that's still resectable. The one in the middle is around some of the vessels, and so that's, we would generally say no, but we don't always say no. And then you can see on the bottom left, there's liver metastases. So again, that wouldn't be resectable, even though the lesion itself is small. And on the bottom one is a distal pancreatic lesion. So these are the types of surgery, and this is what we think about. So curative or palliative. And then some of the things that we do. So then before we even get to surgery, we have to talk to patients. And this is generally what we tell them. I'm fairly blunt when I talk to patients. I'm also fairly, I'm going to say this, Australian. I do speak extremely plainly to patients. So they have a lot of risk for this operation. If it goes smoothly, it's great. If it doesn't, it's extremely bad. So the risks are always simple things like bleeding, pain, and infection. Bleeding can be catastrophic. It can be at the time of surgery, it can be after surgery, and with the advent of ERAS surgery, or early sort of going home, unfortunately they're out in the community and they can have catastrophic bleeds then, so that's something that you have to be aware of now. The risk of pancreatic leak is something that they need to know about, and we do stress considerably. They can become a diabetic. We don't know who will become a diabetic. We know that those that are already sort of insulin-dependent diabetics will stay that way. Or those that have been diabetics for a long period of time may become worse. We may actually improve those that are newly diagnosed, though. Depending on the operation, they can get dumping, whether or not that's early or late, and thankfully we have lovely dietitians who can control most of that for us. And the other things that we do stress are recurrence, death, and that we are unable to proceed at the time of the operation. Okay. So do we do a diagnostic laparoscopy for most patients? We don't these days. Okay, we used to. But with the advent of CTs, PETs, EUS, MRIs, we generally know who's resectable and who's not. If we have any form of suspicion of peritoneal disease, we will do a diagnostic laparoscopy. But it won't tell us if the patient is actually resectable at the time of surgery. We won't know that until we get in there. So we do limit it to our high-risk patients. So here comes the extremely boring stuff. So the Koch-Whipple's procedure is everything that everybody knows about. It's what everybody talks about it. It's basically removing the pancreatic head, the duodenum, the common bile duct, the gallbladder if it's still in, distal stomach, and the surrounding lymph nodes. It's not actually it's what we historically did, and I'll talk about a little bit further. So there is a diagram. Now this is the reason why I'm a surgeon and not an artist, okay? So basically you can see the tumour in the middle one, and basically the red lines are everything that we excise for the Whipples. That's all the division that we make. So then we're left with this free-floating bits that we then need to replumb together. So 1, 2, and 3, and it's pretty much the order that we do it in. So pancreas first, biliary tree, and then stomach. Okay, and then you get the final picture, which roughly looks like that. Okay. Now there are different ways to do every single anastomosis there, and if we were next door in the other conference centre, we'd spend the entire day talking about the types of anastomosis to do and the benefits and the risks with every single one of them. But I'll stop boring you. So I drew the diagrams because these I don't necessarily think you can ever really follow. So this is actually what, when patients come to us, they say, oh, you're going to do a Whipple's, but we aren't. We're going to do this. It's a pylorus-preserving pancreaticoduodenectomy, which was sort of talked about in the 1940s. And basically, we leave the stomach. We divide a few centimetres beyond the pylorus and do exactly the same as the Whipple's procedure. Okay? The reasoning for that is, or the thought of that, was that we retained functionality of the stomach and limited their nutritional and deficiencies. The reason we do that is that there is no statistical difference between the two operations, but the pylorus-preserving pancreaticoduodenectomy is a shorter operation and we lose less blood. Originally we did think it was more physiological, but there is no evidence to show that, unfortunately. And there is some thought that the PPPD may be more osteogenic, but it just depends who you talk to. So now the question is, like I said, we've been pushing the boundaries. So you'll have some patients that will go to a surgeon and they'll say yes, and then you'll have patients who have the similar CT scan and will say no. There is a CT diagnosis of a classification of what is borderline resectable, and again, it's all about the SMA and the SMV. And they talk about a 100-degree rotation around the SMA and 180-degree around the SMV. But unfortunately, on the CT scan, it's not necessarily also what we find. But in general, if it involves the SMA, depending on the age and the surgeon, they might offer the patient resection. If it involves the SMA, they probably won't. And again, that's generally because it doesn't alter their outcome. But in actual fact, if they weren't to have a resection, then their life expectancy would be a lot less. So if they manage to get through an operation where we reconstruct their arterial supply or the venous supply and don't have any complications with that, then they live the same amount of time as somebody who didn't have arterial involvement or venous involvement. So that's sort of why we do it, and I guess we're hoping that with chemotherapy and radiotherapy that it in times will have improved the way we do this and we might offer them a better outcome. These are some of the weird and wonderful things that we do. So if it's in the centre, we might do that, but it's not common. And as you can imagine, the risk of a pancreatic leak is enough for a Whipple's. Do we really want to have two anastomoses? And we really often don't. Then the question is, do we do a total pancreatectomy? We don't offer that for a simple cancer if it's in one particular spot, usually. I'm hoping a few people know about IPMN, but it's a new classification or newish disease process where we thought initially, in order to lessen somebody's risk of developing pancreatic cancer, we should do a total pancreatectomy. But because we know that we don't really know what their risk is, and we know that the risk of brittle diabetes is extremely high, we're not sure that the benefit of doing a total pancreatectomy is actually appropriate these days. Okay. So if we get away from the left-sided tumours in the head and go towards the distal, it's a distal pancreatectomy, really. And that's basically, we take off the pancreas everywhere from the neck to the left towards the spleen. Then the question is, do we take the spleen or don't we? For the most part, if we can spare the spleen, we will. I mean, with the risk of overwhelming post-splenectomy infection, if we can leave it, we will. But we will never compromise surgical margins or cancer oncological staging, okay? We'll often do a split. We see more spleen preserving if we're doing a laparoscopic procedure. And that's often because it's a smaller tumour though, okay. And the other operation is just a nucleation, and that's for the sort of benign tumours. So they can just really, if we can localise them appropriately, they'll just pop out. So we're doing more and more laparoscopic surgery these days. The question is, should we? For distal pancreatectomies, they're very simple for us to do. It's quite easy. We've been doing them for quite some time now. We know that the outcomes are actually quite good, or at least similar to an open procedure. And as I mentioned, if we're doing a laparoscopic procedure, we'll often preserve the spleen. We are starting to do more Whipple's procedures, but we aren't actually, there is no data out there that actually talks about cancer survival, I guess. It's all about, did we get the same amount of lymph nodes? Were the complications exactly the same? Did they survive the same amount of time? Well, they sort of did. And we can do the operation. There is a 20% conversion rate, but I think it's something that will be expanded upon as the years go on. And the other thing is ERAS. You wouldn't think for pancreatic surgery this is something that we do, but it is up and coming, and over the last sort of 5 years it's something that we do quite significantly. And ERAS is all about getting patients in and out of hospital with the least amount of stress on their system. So we don't fast them as much, we feed them sort of up until 2 hours before the surgery. We try not to put drains in, we try and get those drains out as soon as possible. We limit the amount of analgesia we do. We are literally getting them out. Unfortunately, that means we're putting them into the system for you, and that's where the problem becomes for you. And again, that's why I say the CNS is your best friend. So not only do we do sort of cancerous section for curative intent, but they do present with gastric outlet obstruction and obstructive jaundice. Most often we will have all of these symptoms treated endoscopically. If we are doing a laparotomy for a patient that we think has resectional disease and we are unable to resect it at the time, then we will often proceed to doing either one or both of these. And that's because we know that if they haven't presented with obstructive jaundice, then a large proportion of them will develop obstructive jaundice during their stay with us or during their sort of disease process. And the difference between doing an endoscopic procedure and a surgical procedure, the outcomes and complications are exactly the same. Whether or not we do a bypass procedure in terms of the gastrojejunostomy is a little bit controversial, because we know that only about 10%, 20% will actually develop any form of gastric outlet obstruction that is surgically curable or relievable throughout their treatment. So they can actually have a duodenal stent put in if need be. So if you've survived the pancreatic cancer topic, this comes the chronic pancreatitis topic. So this is chronic pancreatitis, the calcification that you can see, the little white spots, that's calcium in the pancreas. And that's commonly what we see for chronic pancreatitis. Now, this is a controversial topic. We've already had a debate in our main conference as to whether or not we should even do surgery for chronic pancreatitis. Coming from Australia, we don't really. It's all endoscopic, it's all just do nothing. It is a little bit more common here in Europe than I was ever aware of, I have to say. And basically, because it's a progressive disease, we do think that in about 10 years, 20 years, their disease process will have what we call burnt itself out. So in actual fact, should we offer them surgery? We know that their pain is due to ductal hypertension, chronic inflammation, and progressive perineural disease. And we usually think the head of the pancreas is the nidus of the inflammation and the cause of the pain now. That's what we think. But the issue is these patients have a debilitating disease. It affects their quality of life. They will see you regularly if they don't see us. So, I mean, we want to do something for them. You want to do something for them. Can we do something for them is the question. And then the other concern that we always have is those with chronic pancreatitis can develop into cancer. So we always have to be extremely mindful of that. So as I sort of said, last resort for a lot of people. They will try endoscopic procedures first. If those don't work, then we'll go on to a surgical procedure. Those that have failed conservative management, so celiac plexus blocks, creon sometimes helps relieve some of their pain. We do nasojejunal feeding at Royal Surrey County Hospital. Now, again, we talked about this randomised controlled trial in the debate. and it's a little bit controversial, but it basically says surgical intervention is better than endoscopic intervention. So the types of operation, it's basically what we want to do is have an operation that basically decreases their relapse rate, relieves their pain, and restores their quality of life, but also, hopefully, doesn't affect their endocrine or exocrine function. Okay, so there's a number of ways to think about it. Decompression of the disease and the pancreatic duct, denervation, so the celiac plexus block type of things, and then surgery, so resection of a typical Whipple's or PPPD, distal pancreatectomy, total pancreatectomy, and then the hybrid procedures that you've all heard about. So this is, believe it or not, we've been doing surgery for chronic pancreatitis since the 1890s. This is the Pusto procedure. It was actually first sort of more described by Partington and Rochelle, but they called it the Pusto procedure because he was the first person to sort of do it. And it's basically the pancreatic duct. We open that up and we hook a small amount, the small bowel to that area. Okay. Low mortality, morbidity is not too bad. Pain relief is pretty good, 75%, but unfortunately they get recurrent pain due to the fact that we may not hook up the small bowel to the entire pancreatic duct, and then they get recurrent disease, what is called a chain of lakes development, where they get recurrent stenosis and therefore recurrent pain. So then there's Whipple's, which you know about. It's good result for pain relief, but again, it's a high morbidity, high mortality operation. We seem to think that, well, we hope that it's going to be less of a concern because the pancreas is actually quite fibrotic, so the risk of pancreatic fistula will be less, and it is. But unfortunately, the duct is actually a little bit smaller, so it's actually a harder operation for us to do. Yes. Total pancreatectomy, again, is no better than the Whipple's procedure and no better than any of the other procedures, but again, you have the severe metabolic consequences, so we don't really offer it. And then we get to the hybrid procedures. Again, these are the things that everybody hears about, the Fraser procedure and the Baker's procedure. So Baker described this in 1972, which is basically resection of the head of the pancreas, leaving a little bit of the pancreas around near the duodenum, and then needing to do an anastomosis to both edges of that. So I've already told you that doing the pancreatic resection is bad in a Whipple's, and we hate pancreatic leaks and fistulas. So as you can imagine, doing that, it's sort of fun. It gives you extremely good pain relief, but unfortunately with all of these operations, even though we're thinking that we're doing it to limit their exocrine and endocrine insufficiency, their disease progression for that continues no matter what we do. So whether or not we operated on them or didn't operate on them, they are still going to develop some exocrine and endocrine insufficiency. So are we actually benefiting any of these? Now, because we're chopping out the entire, almost the entire head of the pancreas, the blood supply to the duodenum runs there, and we have to be extremely careful that we don't hit that. Otherwise, they're going to get ischemia of the duodenum, and then they're going to have more problems than they had when we started. So that's the main risk of this procedure. And then you get the Fraser procedure, which I'll basically, again, is exactly the same outcome-wise in terms of morbidity, mortality, and resolution of their pain. But what we do is basically, instead of taking out the entire head of the pancreas, we basically core it out, get rid of all the calcification that you can see, take as much as we need to, but leave the back wall where the blood supply is, where the ducts are, and then we do the longitudinal pancreatic jejunostomy or the Pusto's procedure. You can choose to do that or not. Okay. And then not all patients, when we see them with chronic pancreatitis, have pain. Some just have gastric outlet obstruction. This gentleman had chronic pancreatitis. He's had coils for his splenic artery aneurysms. He's done extremely well. He has no pain, but he's got gastric outlet obstruction. So we will offer them surgery, obviously. So that's just a bypass procedure, and they can be quite simply done, just laparoscopically. So again, comparisons, there's limited data, unfortunately. It's all single centre, single operation, Not many centres will compare all 3, 4, 5 operations because we don't do them that commonly. But what we do know is that the Beagers and the Freys outcomes are comparable and their morbidity and mortality are less than the Whipple's procedure. Okay? So if that's the one that we're going to do, then that's usually what we're going to do. We'll do the Whipple's procedure if there's any form of concern for cancer in the head of the pancreas. Okay? Now, I'm not going to go through this, but this is sort of really what you wanted to know, but that's going to go through the next slide. But these are the things, again, that we worry about that are going to, and the complications of our surgery, unfortunately. And again, that's the fistula. Patients potentially will go home with drains these days, like I said, with the ERAS procedure or any other concern. They'll go home with drains, and unfortunately, it's something that you guys need to cope with. Somatostatin we prescribe routinely for anybody who's had pancreatic surgery. The Cochrane, it's prescribed for a number of reasons and a number of conditions. For pancreatic fistula management is about the only evidence that Cochrane will tell you it shows any form of sort of working, and that's a little bit contentious as well. Okay, and I'll leave the rest up to Mr. Menezes.
Very much.